Hi everyone. Welcome to today's NCLEX webinar on problems with labor here with Naxlex. I'm Maria and I'm an RN. I'm an NCLEX prep educator and you may have met me before. If not, nice to meet you. I will be hosting your webinar today and I'm really glad to have you here, whether you are studying for the first time or if you are reviewing again for the exam, you're in the right place. Today's webinar is going to break down some key labor complications. Then we are going to have a case study and some questions. And about halfway through the webinar, which is around the 1 hour mark, we are going to take a short break. We can stretch, use the restroom, hydrate, take a few breaths, whatever you prefer. And throughout the webinar, if you have any questions, feel free to drop them in the chat. I will do my best to answer them when I pause between slides and just am able to look in there, see what your questions are, and address each and every one of them as much as I possibly can. And if you're looking for more practice outside the session, make sure you check out the Naxlex QBank. It is one of our best tools out there. We have lots of different questions, adaptive questions, NCLEX style. There are cheat sheets, video rationales walking you through the questions, and we also have lots of different features. I'll talk a little bit more about that later if you guys are curious, so you let me know. And I'm going to go ahead and dive in and get started. So I hope you're all feeling good today. Feel free to say hello in the chat and welcome. Drop your name, where you're from. Are you taking the NCLEX for the first time? What's your goal in nursing? Where do you want to work? You want to work in labor and delivery, postpartum, ER? What's your passion? Tell me in the chat. I'll comment on it when we are between slides and I have a minute here. I'm going to roll back and look at your guys' comments and read them out loud. Well, let's get started. So today we have a few topics we're going to go over. We're going to go over premature rupture of membranes, preterm labor, dystocia, fetal distress, prolapsed umbilical cord, and amniotic fluid embolism. And like I said, we are going to go over some strategies and some practice questions as well as a case study. Hopefully we'll have time to go through all of it. It is a lot of content, so I hope that you guys are able to get as much as you can from this. Get comfy, get yourself a drink and something to write with or type with, whatever you like, however you like to take notes. The first topic I want to jump into is premature rupture of membranes. Again, if you have any questions, feedback, comments, requests, drop them in the chat and I will take a look at them as soon as I can. But let's go ahead and talk a little bit about premature rupture of membranes. Sometimes this is abbreviated as PROM or PROM. And this takes place when the amniotic sac breaks before labor actually begins. And if it happens before 37 weeks, we call it a preterm premature rupture of membranes, or PROM. This condition is actually a really big NCLEX topic because it carries a lot of serious risks for mom and baby, including infection, preterm labor, of course, and even possibly cord prolapse. That amniotic sac is really what cushions and protects baby in there. So the challenge with PRM is actually knowing how to properly assess the patient and when to intervene, and of course, how to prioritize infection prevention without rushing into delivery unnecessarily, especially if the baby is still very young, very preterm. So let's go ahead and break this down. So PROM, like I said, refers to the spontaneous rupture of the amniotic sac. And sorry, go ahead. I thought I missed one of you guys. If you said something and I didn't hear you, say it again. And I see everyone saying hello in the chat. Welcome. All right, guys. I'm going to go ahead and keep going. If I didn't hear you, go ahead and try me again. So like I said, PRM takes place usually before the onset of labor when there is a spontaneous rupture of the amniotic sac, right? We often hear that as my water breaking. And if it does happen before 37 weeks, again, it is classified as PROM, or preterm premature rupture of membranes. And this condition does increase the risk for maternal and fetal infections, for preterm labor, and for cord prolapse, like I mentioned earlier. Now, the longer the time between the rupture of the membrane and the delivery, the higher the risk for complications is. One of the complications being chorioamnionitis, which is an infection that can happen from the sac rupturing early, and then microorganisms, pathogens being introduced in there. It's a very sterile environment. So once that protection is broken, there isn't a whole lot keeping baby safe from pathogens. So that time between the membrane rupture and the delivery is actually known as the latency period. So it's very important as a nurse for you to understand and for you to educate your patient appropriately um, on, if they feel any leakage of fluid, if there's a pop, if there's some kind of anything really that they're uncertain about, right? Maybe they're like, maybe I peed myself. You don't know. It could be a rupture of membranes, right? So better to be safe than sorry. It's okay if you waste a trip to the hospital. You're going to come in. We're going to check you and make sure that your membranes are still intact. And if they're not, then some interventions may be needed in order to prevent infection. So the thing that we like to ask our clients is, when did it happen, right? Because the longer the time, the more likely this client is to develop an infection. When did it happen? Oh, looks like I might have gotten kicked off and back. I hope you guys were able to capture what I was talking about. I'm gonna go ahead and go back here in case you guys didn't catch what I was talking about. It looks like the meeting got kicked off and then back. So what I was talking about is the assessment when it comes to figuring out what is important to ask your client about if they did experience a rupture of the membranes. So we're going to go ahead and jump into that assessment here. And again, the first thing your client will likely tell you is that they felt some discharge that was larger than usual. Maybe they felt a gush or a trickle. Maybe it was clear, maybe it was slightly yellow, right? So the questions we're going to be asking are going to determine how we're going to intervene. The first question we really want to look for is the timing. When did it happen, right? When did it happen? Do you remember around what time? What color was it? Was it clear? Was it yellow? Was it stained green? That could be meconium. Was it stained red? That could be blood, right? So we want to ask all those questions: timing, color, and then of course we need to know the odor of the fluid as well. Did it smell fishy? Did it smell bad? Or did it just have no smell? Or did it smell like urine, right? So these are
Right now,
to ask about. Sorry.
screen. We can see your screen.
Oh, that is so weird. See, I feel like somehow I got kicked off and then my screen disappeared. Thank you for letting me know. There we go. That is so strange. Zoom does the weirdest things sometimes. I am so sorry, guys. All right. So, again, we're mainly talking about here the timing, the color, and the odor of the fluid, right? And once the patient does come in, we are going to use a sterile speculum to do an exam on them. And this is kind of a double-edged sword though, because if they have had a rupture of membranes and we are performing repeated vaginal exams, this could be increasing their infection risk. So our sterility and our hand hygiene and infection control really comes into place here. We want to minimize vaginal exams as much as possible if the membranes truly have been ruptured. Um, so we want to be a little bit less invasive initially, right? So what we can do is we can do the nitrazine test. This checks the pH of the fluid that has been leaking. Amniotic fluid would be alkaline, so it would likely turn more towards blue. The Ferning test confirms the amniotic fluid by visualizing a crystal-like pattern in a microscope. So this would involve taking a swab, maybe getting a sample of it, and then taking a look under the microscope. That would be the Ferning test. The nitrazine test is where we test the pH. Now remember, we are going to monitor closely for infection signs, especially if the rupture occurred more than 18 hours ago. Now this client is at a much higher risk for infection. We're going to monitor for any signs, right? Like if they have a fever, if they're tachycardic, if they're having tenderness or pain, if there's a strange odor to the fluid. And we are going to avoid vaginal exams as much as we possibly can. Now, the management of this condition is really going to depend on the gestational age and, of course, if there is an infection present. Now, let's say this patient is PPROM, so they are preterm premature rupture membranes at less than 34 weeks, but there is no infection. The goal here is going to be to delay labor and to administer betamethasone so that we can mature baby's lungs faster in case delivery is imminent. And then, of course, we're going to monitor mom very closely. Now, if there is an infection present, if we do see mom is running a fever, there is maybe a foul odor to the amniotic fluid, mom's white blood cell count is high, then that tells a different story. If the fetus is mature and there is a fever present, then delivery would often be the next step here. Now, of course, we're going to need antibiotics on board like ampicillin, erythromycin. These can be given to prevent infection and to prolong this latency period. And in addition to that, pelvic rest is going to be critical here. We are not going to be doing any digital vaginal exams. There will be no intercourse or anything vaginally inserted. So no transvaginal ultrasounds, no vaginal checks or cervical checks, no intercourse, nothing like that. Because we really want to prevent as much as possible adding any pathogens or introducing microorganisms while mom is in a very vulnerable stage and baby is in a very vulnerable stage where they are prone to infections. I do have some questions and answers here for you just to kind of remind you of what we went through. And I do this sometimes. I don't always do the Q&As because we don't always have time, but let's go ahead and go for it this time. So asking here what test confirms amniotic fluid leakage, and that would be the Ferning test, which is when they do that swab and they do a microscopic pattern. What intervention is going to be most important after PROM, and that's going to be to monitor for infection, right? The infection we're at risk for here would be chorioamnionitis. Now, what medication promotes fetal lung maturity if less than 34 weeks? That would be betamethasone. Why are vaginal exams limited with PROM? And that is to reduce the infection risk, right? We're reducing the amount of microorganisms that we are introducing. to the vaginal area, and then which finding requires immediate provider notification with a premature rupture of membranes, and that would be maternal fever or fetal tachycardia. These would be signs of infection. Now let's move on to another high priority complication on the NCLEX here, super relevant, not just on the NCLEX, but in clinical practice, especially if you're going into labor and delivery, or if you have rotations in labor and delivery, right? We're going to talk about preterm labor here, and this refers to labor that begins before 37 completed weeks of gestation. And it's actually one of the leading causes of neonatal morbidity and mortality. So it's very, very important to recognize it early and to intervene early. And a lot of the NCLEX questions might ask you how to recognize these early signs, what risk factors you need to screen for, and of course, what to do, right? That's going to be the biggest thing on the NCLEX is really testing your ability to prioritize and to choose the adequate and safe interventions for both mom and baby. Now, do you need to stop or delay labor safely, or is delivery imminent, right? So we're going to go over what preterm labor looks like. So let's go ahead and dive in here. So preterm labor is more than just having a few early contractions. It actually involves true labor, right? And there's a big difference between true labor and false labor. Now, true labor is going to involve both contractions that do get closer and closer in frequency, and also that get more painful and more intense over time, in addition to cervical changes, right? So if we just have contractions but no cervical changes, those might be false labor contractions. They might be Braxton Hicks. Sometimes patients can be in false labor. They come in, they get measured, they're having contractions, but no cervical changes are happening. So preterm labor here would involve both contractions and cervical changes before 37 weeks. And in this case, the cervix would begin to shorten, to thin, which is also called effacement, or to dilate, or all of it. And preterm labor can be caused by several different things. It can be caused by infection, by trauma, by multiple gestation. That's a very common one. And even dehydration. That's why they say if mom is having contractions, let mom hydrate, lay down and rest. And if the contractions stop, then we know it was just Braxton Hicks. But true dehydration can potentially trigger preterm labor. So this is a very, very critical time window, because we know that early delivery can lead to poor outcomes with neonates, such as respiratory distress syndrome, intraventricular hemorrhage, sepsis, and lots of different long-term complications for baby. But the goal here is going to be able to recognize preterm labor early and to intervene in order to keep baby inside as long as it's safe to do so. The way that we would assess for
Professor,
preterm
please
labor here
quickly,
would
can
be,
I say the previous slide, please? Thank you
well,
for just a few seconds.
oh, the last one?
Yeah, thank you. Yeah.
Yeah, absolutely. And while you take a look at it, I can talk about the mnemonic here, and it's TACO, which is kind of a funny, silly mnemonic here, but it is for time of rupture, amount, color, and odor. Again, this would help us
Okay.
if mom comes in and says, you know, my water broke yesterday. I didn't really think it was much. I thought I peed myself. So I'm coming in to get it checked out. And those were the questions we'd be asking. What time did it happen? How much came out? What was the color? And was there any odor to it? You let me know when you're ready, and I'll move forward to the next one.
I'm okay. Thank you, Ma.
Yeah, absolutely. Thank you for letting me know. So again, assessing for preterm labor here is going to look like asking the client the right questions, and then of course doing a focused physical assessment and assessing labs as well. We are going to ask what their contractions feel like, right? How often are they happening? Are they happening more than 4 times in an hour? Are they having pressure anywhere? Are they having lower abdominal pain, pain in the lower back, cramps, any changes in discharge? Are they having bleeding? How often and how strong are the contractions, right? What's their pain like? But in addition to our interview questions, we are going to use two tests. We have one called fetal fibronectin, and this is a protein that kind of acts like a glue between the amniotic sac and the uterine lining. And if we do find that in vaginal fluid, then it might mean that that glue is kind of breaking down, which means labor is near. Now, it's not as often that we would be checking for this, but of course, if a person comes in before 37 weeks and we are pretty certain that preterm labor may be happening, then we might check that. We might also do a transvaginal ultrasound as long as there is no bleeding and maybe they haven't had a rupture of membranes yet. A transvaginal ultrasound may be appropriate in this case to measure the cervical length. Any less than 25 millimeters would be concerning. Now, these tools can help us to figure out whether we need to act fast or we need to be monitoring very closely in order to act fast if something does happen. Of course, if their contractions are greater than 4 every 20 minutes or greater than 8 per hour, or if they're dilated more than 2 centimeters or effaced more than 80%, the more symptoms they have that we put together, the more they're at risk for preterm labor continuing and delivery being imminent. If we do catch preterm labor early, then we are able to stall it with some medications called tocolytics. You might have heard of these in nursing school. Think of these as kind of like labor stoppers. We have a few different options, but the three big ones are going to be nifedipine, which is a calcium channel blocker, terbutaline, which is a beta agonist. Unfortunately, they all come with side effects. This terbutaline can cause maternal tachycardia, so we are going to be very alert to mom and baby's cardiovascular status. And then we also have indomethacin, which typically is only used before 32 weeks because it can actually close the ductus arteriosus prematurely. As we know, NSAIDs do have that ability to close those heart pathways. So this one would be another option here. Like I said, it is an NSAID. But we would also be giving corticosteroids to boost lung maturity for baby. So again, betamethasone and then mag sulfate for fetal brain protection. Now, of course, we are always going to monitor for side effects and contraindications of any of these medications. For example, if you have a mom that has a comorbidity, that has some kind of a cardiac issue or uncontrolled diabetes, we are not going to be giving them terbutaline, right? So we are going to be monitoring mom and baby closely. And we do have that little mnemonic there. It's not time, just to remind you of the three big tocolytics that we do use to stop labor: indomethacin, nifedipine, and terbutaline. And we have another little set of Q&As here just to kind of review what we just went through. What does a positive fetal fibronectin test suggest? And it means that we have an increased risk of preterm labor within 7 to 14 days. Which medication is given to mature fetal lungs? That would be betamethasone. Which medication provides neuroprotection for the fetus? That would be mag sulfate if less than 32 weeks. The earliest sign of preterm labor would be regular uterine contractions with cervical changes. And which medication is contraindicated after 32 weeks gestation? That would be indomethacin, again, because it can cause closure of the PDA. Now let's go ahead and move into dystocia. This is another really important labor complication here. It is another name for a difficult or abnormal labor. But before I do so, I want to go ahead and check in on you guys. I see that you guys were letting me know about my screen here, and I am so appreciative of you that spoke up. And I see someone asking about a fibronectin test. Again, the fibronectin test is used to assess the risk of preterm labor and imminent birth in people who are pregnant, who are experiencing symptoms of preterm labor, such as they're having contractions, they're having surgical changes. We would be measuring the amount of that fetal fibronectin, which is the protein that holds the amniotic sac together to the uterine lining. in the vaginal fluid. So it'd be testing essentially the vaginal fluid for fetal fibronectin. And again, it does help to predict if delivery is imminent within the next 7 to 14 days, because it's letting us know that the amniotic sac is kind of separating from the uterine lining. So in this case, we would be using a swab to collect a sample, of course, of the vaginal discharge, and then we would analyze that sample. That could be done in a doctor's clinic or in the ER, in the labor and delivery unit. So it's a very, very useful test. And then let me see here. Can I go back? You are very welcome. You guys want me to go back to this one? I'll leave it up here for a second for you guys. Let's see if you had any more questions. No more questions so far.
Yeah, this one is fine. The recap of what you went over just a while ago. So the recap of everything with the questions and the answers.
Oh, sure.
Yeah,
Absolutely.
thank you so much.
No problem.
This one, yeah. Thank you.
Of course.
I have a question. So in terms of the medications, are they given in any specific order or just based on the assessment of the patient?
Yeah, it's definitely given basically depending on the patient, right? It's going to be on an individual case, right? Case by case basis. So it depends what's the gestational age of the client that you're talking about. Has their membrane ruptured? Do they have any comorbidities that prevent them from taking a specific medication? So it really depends on the assessment that you did or that the doctor did. It really depends on the specific situation that you're in. But typically here, this would be the main medication that we would be giving would be the nifedipine, would be the one that we would be giving. Again, if the patient is less than 32 weeks, we could potentially give indomethacin. If the patient isn't able to take terbutaline for some reason, then we would give another one. So again, it's just based on like, do they have any allergies? What are their comorbidities? What medications are they able to take? So there's not really a specific order that you would do for that. Let me see here. I hope you guys were able to get that Q&A page. And I'm going to go ahead and jump into dystocia here, which is just another name for like a difficult labor. For an abnormal labor, it doesn't necessarily just mean shoulder dystocia. I know we hear that term a lot. So when we hear the word dystocia, we're like, oh, shoulder dystocia. But dystocia itself just means the labor is difficult, the labor is abnormal. This is something that you may see, in both real life labor, of course, in the delivery room and on the NCLEX. And it can happen when basically something just interferes with the normal progress of labor, whether it's if mom doesn't have enough, strong enough contractions. We talked in our last maternal newborn health presentation about the 4 Ps, right? The powers, the passage, the passenger. Whether it's got to be one of those 4 Ps that could lead to dystocia. So it could be the contractions aren't strong enough, the cervix isn't changing, the baby is in the wrong position, the pelvis may be too small for the baby to fit through, right? So if you guys remember, we had the powers, which are the uterine contractions, the passenger, which is the baby, and after delivery we have the placenta, the passageway, which is the pelvis and the birth canal, and then the psyche, of course, which is the one that's least talked about, but it is very important. It's the patient's emotional state, and it can heavily affect how the labor is going to go. It can stall labor, it can help labor move along. So very, very important to keep all of these in mind. And of course, like I said, dystocia happens when one of these Ps aren't working well, or more than one aren't working well, right? The more of the Ps that aren't working well, the more complications we're going to see. So let's go ahead and dive in here and see what we need to do when one of these things go wrong. Now, for dystocia, Again, this is kind of a blanket term, right? It's not only talking about one type of complication. It just means labor isn't progressing normally. There's got to be a reason behind it. As nurses, it's our job to figure out what is stopping it, right? So that could mean, again, mom's having weak contractions, maybe baby's not positioned correctly, maybe they're malpositioned, maybe they're breached, they're transverse, maybe they're OP, right? Or maybe mom has a smaller shaped pelvis that's not really optimal for the size of baby. But again, we are going to be looking at those 4 Ps, the powers, the passenger, the passageway, and the psyche. And any one of these or a combination of them can result in a stalled labor. Now, sometimes contractions can be hypotonic. And what that means is they're not strong enough. They're way too weak to cause any cervical changes. Sometimes contractions can be hypertonic, which means they're too strong, or they are frequent, but they're ineffective and painful. Now, when it comes to a problem with the pelvic structure, this is going to be very important as well, because this is when a cesarean may be required. And this is going to be a common NCLEX topic here, especially in relation to labors that are very prolonged or that begin to develop complications. Sometimes you may have something called failure to progress. And this is when you're going to need to initiate some interventions, right? Maybe you're getting mom to walk around a little bit, get some movement in there. Maybe you're going to start some Pitocin, or it's potentially possible that they could switch to a surgical delivery, to like a cesarean. Now, when you're assessing for dystocia, I want you to look for a few different things. Again, you're going to be thinking about those 4 Ps, right? Is there something wrong with one of the Ps and why it's not moving? Maybe we have a cervical change that it's either not enough or there's just no cervical change after mom is having hours and hours of contractions. Maybe the uterus is overworking or not working hard enough. Maybe mom needs to relax, or mom may need more activity. It really depends on the individual case. And sometimes baby may just be stuck with a poor position. Sometimes the occiput posterior position can be one of them, leading to back labor that is very prolonged and painful. Or the pregnant person may be very mentally and physically exhausted. Maybe they need a nap. Sometimes that's all they need to get things kick-started. So you may see questions on the NCLEX where labor is prolonged and there's no dilation or fetal descent that's taking place. So that should prompt you to right away think about, okay, we have dystocia happening. Let's think about our 4 Ps and the information given to me. Which of the Ps is going to be the main problem, right? And figure out that way what it is that you need to do to intervene. And again, dystocia is going to be kind of a coordination issue because you're likely going to see multiple different interventions that are required. So, for example, you may have to reposition mom to optimize the angle of the fetal head, or you may have to give them Pitocin or oxytocin. Some places it's called oxytocin, some it's called Pitocin. It's the same as the hormone that our body produces, right? But it's the pharmaceutical version of it. So if contractions are too weak, not strong enough to cause cervical changes, we are going to give Pitocin. And if they're too strong, but there's no changes happening, we may give mom some pain relief and tell them to rest it out, take a nap, and that may get things going again. But if the baby's in a bad position, the provider may be able to do a manual rotation, or they may consider vacuum delivery or forceps assisted delivery. And of course, if all else fails, then we might need to move to a more invasive technique, especially if there are signs of fetal compromise, or if we have the disproportionate size of the pelvis to the baby, then we may have to prep for a C-section. And of course, your role as the nurse, not just on the NCLEX, but in a clinical setting, would be to recognize, hey, labor isn't progressing. I need to go ahead and escalate this appropriately and let the provider know what's going on so we can move forward with a different intervention. And we do have a mnemonic here, props for position change, rupture membranes, oxytocin, pain control, and surgery if needed. I do have some questions and answers here for you, like what is the nurse's first action when labor stalls in the active phase? And it is to reposition the client to enhance descent. Don't underestimate the power of gravity movement and repositioning mom. It actually is one of the greatest interventions. Now, which finding indicates a hypertonic uterine activity? That would be if we have very frequent contractions with no cervical changes. And what does CPD mean? It actually means cephalopelvic disproportion, and it means basically the baby can't fit through the shape or size of the pelvis. This is not a very common situation, but it can happen. For the most part, most moms are able to accommodate baby through the pelvis, but sometimes they may not be able to, and the cesarean may be needed at that point. And of course, we know our medication that stimulates uterine contractions is going to be Pitocin, also known as oxytocin. And then a C-section may be indicated in dystocia when we have CPD or when we have signs of fetal distress. And I do want to kind of go back to when you guys were talking about when you asked me about the medications and what order they go in. Typically, we would be choosing only one tocolytic to give. Now, if you were talking broadly about all preterm medications, like if you were talking about like the betamethasone, the mag sulfate, all of those, then that's a different story. And I was thinking about that when I was just talking about dystocia with you guys, and I wanted to kind of go back and touch on it to make sure that I give you all the information about it, right? So again, we would be choosing the tocolytic medication depending on the mom's individual case, whatever may be best for them, right? We're either going to give nifedipine, terbutaline, or indomethacin, depending on what their gestational age is, on whatever. But the first thing we're most likely going to give is going to be that betamethasone, because we need baby's lungs to mature as fast as possible, especially again, as long as we possibly can give baby before delivery would be better, because this gives baby a better chance to have adequate respiration when baby comes out. And so that baby's lungs are mature enough to maybe not breathe on their own entirely, but maybe they're a step further than they were initially. Especially if they are very, very premature. And then, of course, after that betamethasone, we would be giving those tocolytics, right? We need to suppress those uterine contractions long enough to kind of allow the betamethasone to work on baby. So we would definitely be giving those in conjunction, or we would likely be giving tocolytics after the betamethasone. Betamethasone would be most likely the first and most important medication. And then, of course, we can't forget about that mag sulfate. We would be giving it before 32 weeks, like I said earlier on that previous slide. It would be providing neuroprotection for the fetus, right? We don't want the fetus to have like a nervous system irritability because of that traumatic experience. So that mag sulfate would help immensely with that. And then, of course, this is a separate case too, is if mom has an infection, right? Then we would be giving antibiotics alongside if they did have a premature rupture of membranes, or if they, of course, had their positive group B strep, or if we don't know what their group B strep status is, right? We might give them antibiotics anyways, just in case. So if, like I said, if your question earlier was regarding all the broad medications that we give in preterm labor, then that would likely be the most important order for them to go in. Well, let's talk a little bit about fetal distress here. We still have, I believe, 3 more topics to go over. And then after that, we are going to talk about some test taking strategies, and then we're going to do our case studies together. So let's move into fetal distress here. Again, this is another high yield topic. This is referred to any sign that baby may not be doing well, right? Baby's not doing well in utero. Usually this is going to be because of inadequate oxygenation. Baby's hypoperfusion. Maybe there's placental insufficiency. Maybe the cord is compressed, or maybe the uterus is overactive, right? We have a hypertonic uterus that's contracting closer and tighter than it should be. And that's not giving baby enough recovery time in between contractions to be adequately oxygenated. So if these signs aren't recognized quickly and managed quickly, then this can lead to hypoxia in the fetus. This can lead to potential acidosis and even death. So again, as nurses, we have a really big job to recognize these signs and symptoms and to know when to escalate them to possible emergency delivery, what to look for in the fetal monitor, how to let the provider know, when to let the provider know. So let's talk about it. So fetal distress is kind of, again, another blanket term here, kind of like dystocia that we use to describe signs that the fetus isn't really tolerating labor very well, or that maybe they are suffering from something more serious like hypoxia or acidosis. And fetal distress may show up through non-reassuring fetal heart rate patterns. The key ones that I want you to remember are late decels. Late decels typically mean there is placental insufficiency. Also, prolonged decels, these are going to be greater than 2 minutes. And then if the fetus has bradycardia, so if the heartbeat is below 110, this is going to be a big red flag for us. And then, of course, minimal or absent variability here is going to show that the nervous system of the fetus isn't reacting properly to stimuli. Now, another big red flag we're going to see here is if mom has amniotic fluid that is stained with meconium, especially if it's thick, right? Not if it's just like a very, like maybe just a little light tinge to it versus like a thick stain of meconium in the amniotic fluid. This could be very dangerous for baby's respiratory well-being. It may mean that baby's under stress. So again, understanding here how to interpret these signs is going to be key, right? All right, let's see here. So some intervention.
Sorry, I have a question, but this is not pertaining to your slide. This is just a question that I had previously on one of the Q banks. When they
Sure.
refer to the statement mirroring contractions, what is exactly does that mean? Mirroring.
Oh, sure. Yeah, that's a great question. So basically, let me show you actually an image here.
Is that a good thing or a bad thing?
I'll show you right now. This is a great sorry, I'm trying to pull up the image here so you guys can take a look while I tell you. It's really going to help you to like visualize what I mean here. So we have different kinds of variations in the fetal heart rate as it relates to contractions, right? So basically, when you're having early decelerations, this is when the fetal heart rate is mirroring the contractions. As you can see here, the fetal heart rate is kind of mirroring the contraction. So what this means is basically that the head is being compressed, the head of the fetus is being compressed during a contraction and then going back to normal. And this is actually a fine, reassuring sign. It means that things are okay, because baby's head is being compressed as baby's being pushed down the birth canal as the uterus is contracting. However, it's when it loses that mirroring pattern, such as in a late deceleration or a variable deceleration, that we're concerned. And these would be indicating that there would be some uteroplacental insufficiency. So maybe baby's not getting enough oxygen, or we have umbilical cord compression. Now, for both cases, we would be repositioning mom. We'd be administering oxygen, and of course, we'd be continuing to monitor very, very closely. And NIV fluids, of course. So I'll go over that a little bit with you guys here with the interventions. But does that make sense here with the mirror?
Yes, thank you so much.
You are so welcome. Thank you for asking that. That was an excellent question and very, very relevant to what we're talking about. So again, when it comes to
the previous slide, please, before you start this.
Go back to the last one.
Yeah, the previous one before this.
Got it. I'll let you look.
All right, thank you. I got it.
You're welcome. All right, let's go ahead and jump into the next one here and talk about some interventions. Thank you guys for asking and letting me know what you needed. So when it comes to interventions for fetal distress here, these are pretty easy to remember. Just get in your brain the stop mnemonic here. And as you can see here, we have stop, right? So basically what this means is if you are running Pitocin and you are seeing fetal distress on the monitor, the first thing you're going to do is stop Pitocin because if the labor is being augmented with Pitocin, then that means the uterus may be overstimulated, and that could potentially be causing the problem. It could be causing fetal hypoxia or irritability in the fetus. The next thing that you're going to do, whether you're running Pitocin or not, again, if you were running it, you stopped it. If you weren't running it, then the first thing you're going to do is you're going to turn patient. Here it says left or right lateral, but the best position is going to be the left lateral position. So you're going to turn pregnant mom on her left side, and this is going to help improve placental perfusion. Again, you don't want moms supine or laying on their back. Even laying on the right side may not be as good. On the left side is always going to be superior. Now, you're going to administer oxygen at this point via face mask. You're going to be giving between 8 to 10 liters per minute to assist in that perfusion to the fetus. And then last but not least, you are going to give some IV fluids. You will be giving an IV bolus to help restore the circulating volume, again, to push that perfusion to the fetus. So this is going to be your order here of interventions that you're going to do when you do see any fetal distress to help to give that fetus maximum perfusion, adequate oxygenation, and you're going to notify your provider ASAP and monitor mom very, very closely. If for some reason these interventions are not sufficient, then we may have to prepare for an emergency cesarean. So again, if you do have umbilical cord compression, one of the interventions we may consider is an amnio infusion. But if the distress continues or you see some more dangerous tracings, then it is time to prepare for a C-section. And again, you would need to know when to call the provider and when to act immediately. Now, what's the priority intervention for late decelerations? And that is going to be to reposition the patient and apply oxygen. And again, remember the left side is going to be superior here. And then which finding is most concerning on the fetal monitor? That is going to be absent variability with bradycardia. And I do have a couple of charts here that I do want to share with you guys. I am going to put them up during our 5-minute break so you guys can look at them and write them down if need be. And then what does meconium stained fluid suggest? This does suggest that the fetus is under distress, right? Because that means they had a stool, they had a bowel movement in utero. And it also means there is a huge risk for aspiration pneumonia, right? Because if the fetus has had a bowel movement, now they might potentially inhale that fluid that does have meconium. Again, the thicker the worse, right? Because we don't want them to be inhaling meconium into their lungs. This could settle in there and cause aspiration pneumonia. So a very dangerous complication here. And then what does the O in STOP stand for? That would be oxygen via face mask at 8 to 10 liters per minute. Again, remember STOP mnemonic means stop oxytocin, right? Or stop Pitocin infusion. I'm going to go ahead and put that back on the screen here for you guys. Turn the patient to the left, oxygen via face mask, and then push fluids, right? We're going to give a bolus of IV fluids to help increase circulation and perfusion. And then what medication reverses uterine tachysystole? That would be terbutaline. And I do want to tell you guys a little bit more about category 2 and 3 fetal heart rate tracings. You might find questions about these on the NCLEX. So when it comes to fetal heart rate tracings, and again, I'm going to put up another chart here for you guys to understand a little bit more. There are 3 categories. Category 2 is going to be an indeterminate category. This means it's kind of a gray zone. It's not really reassuring, but it's not really alarming. It's kind of like you don't really know, right? It just means you need to continue observing and you need to be aware and prepared to possibly intervene. And this may include if the fetus is having any baseline changes to their heart rate. So if they are becoming tachycardic or bradycardic without absent variability. So if the heart rate is going above 160 or below 110, they may have minimal or marked variability. They may have an absence of accelerations after fetal stimulation, which is showing us that their nervous system isn't reacting appropriately. They may have recurrent late or variable decelerations with moderate variability. They may have prolonged decelerations. So there's lots of different possibilities here. And if you are seeing a category 2 tracing that's a gray zone, that's indeterminate, you don't really know if it's alarming or if it's okay. Of course, you're going to assess the full picture. You're going to, assess mom. You're going to assess your ABCs, like what labor stage is mom in? What's the status? Is mom doing okay, right? How are her vitals? You're going to reposition mom to the left side. We're going to administer the O2 and give some IV fluids. Of course, we're going to stop oxytocin, right, if we're seeing the fetus is in distress. And we are going to notify the provider so they're aware, and we're going to continue to monitor very closely. Now, between category 2 and category 3 is going to be a lot more dangerous. This is going to be abnormal, and it is going to be a red flag. And this does indicate that the fetus is possibly hypoxic or acidotic. So this does need immediate intervention. Let me see if I have my chart up here. I'm going to leave this one up for you guys while I'm talking about it. So when it does come to a category 3 tracing, again, this is a red flag if the fetus does have absent variability. And I do have something here about the variability for you guys, so you can kind of take a look at what that means. So if the fetus does have absent variability and they have any recurrent late decels or variable decels, then we need to be on high alert. We need to call for help immediately. We need to, again, do our stop mnemonic, right? We're going to stop oxytocin, turn patient to her left lateral. We're going to give O2. We're going to bolus some IV fluids, and we may prepare for delivery at this point. We are going to document thoroughly, which we may not have time to do. So we may need to call for help, right? So somebody else can help us with interventions. Maybe someone can take notes or quickly document at the computer. And of course, we are going to notify the provider immediately. Now, I do want you to remember your veal chop mine mnemonic here when it comes to these changes in the fetal heart tracings, right? And it means if you're having variable decels, this means you likely have cord compression, so you want to move mom. And again, this looks like laying mom on the left side. If you have early decels, remember we talked about the mirroring pattern. This means we have head compression with contractions. So at this point, you're going to identify the labor stage, right? So we're going to see, are we at the proper labor stage to be having early decelerations? If we have accelerations, that's okay. That means we don't need to do anything. But if we do have late decels, then that means we have placental insufficiency. So we have to execute POISE, our emergency protocol here. And I don't know if you guys remember what POISE
Professor, what does POISE stands for?
It's basically very similar to our stop mnemonic here, and it's going to be our protocol of what we need to do when mom and baby are in distress and we are having an emergency situation. Okay, so we have the passenger, we have the outlet, we have the intensity of contractions, we have support and psyche, and we have engagement. Give me a second here. Let me go ahead and pull it up. Let me see. I thought I had an image here to pull up for you guys so you could copy it down. 1 second. I'm trying to find the page here for you guys. I don't think I have it. I think it's on my last presentation, unfortunately. I don't have a way to pull it up for you guys, but I am going to write it in the chat for you guys so you guys can copy it down in your notes. But I'll also tell you verbally. I just know it's so much easier to look at the mnemonic. But that one was in our last presentation. So POISE, again, it's very similar to your stop mnemonic. So P is going to stand for changing the position of mom, right? So always left lateral is going to be the position that is the optimal position to improve perfusion when mom is in labor and baby is in distress. Of course, O is going to stand for the oxygen here, right? I is going to stand for the IV fluids. S is going to stand for stop Pitocin if you haven't already. And then E is going to stand for emergency, right? You need emergency help, so you're going to notify the provider, or you're going to evaluate if delivery is imminent. So it's extremely similar to your stop mnemonic. It's basically the same thing, just kind of in a different order, but basically the same way. If you have Pitocin running, you're going to stop it. You're going to change mom's position. You're going to give oxygen. You're going to give IV fluids, and then you're going to notify the provider and prepare for delivery if necessary. And I am going to try to copy that here into the chat for you guys. For some reason, Zoom has been giving me issues with copy and paste into the chat. I'm going to leave this up for you guys here. We are right at the time for our break, our little short 5-minute break here. If you guys have questions that you want to ask me, please throw them in the chat so that as soon as I come back from break, I can go ahead and start answering those questions for you guys. Or if you don't want to put them in the chat, just write them down and then you can ask me when we resume here. But go ahead and take a small brain break. Stretch your body nice and tall and get yourself a refill, use the restroom, or just take a few breaths and get a little break from my voice talking here. And then we'll come right back in 5 minutes. We will finish our last two topics. We're going to talk about prolapsed umbilical cord, and we're going to talk about amniotic fluid embolism. These are two huge high yield emergencies on the NCLEX. So we're going to discuss those. And then we're going to talk about some test taking strategies real quick, and we'll jump into our case studies. So go ahead and take your break, and I will see you guys in about 4 to 5 minutes. Hello and welcome back from our break. I hope you guys were able to get a nice stretch there and a nice little brain break. Sometimes that is needed, right? Instead of just talking to know tomorrow, especially with all this nursing content. It is so comprehensive. And before I do go forward with our next couple of topics here, I do want to address some of your guys' questions in the chat here. I did scroll up and see what you guys were asking about. So I did answer about the fibronectin test. The next question was about explaining the mnemonic ROM. So I want to go ahead and break it down for you guys. So this mnemonic stands for rest, observe, and meds. And this does mean for the premature rupture of membranes. The letter R for rest stands for pelvic rest, right? We want this person to rest, not just physically, but we want pelvic rest, meaning no vaginal exams, no intercourse, no anything being inserted vaginally, because the ruptured membranes do increase the risk of infection, such as chorioamnionitis. So we want to minimize the times that we are introducing any pathogen or microorganisms into the vaginal canal. And then the letter O is going to stand for observe, which means we're carefully monitoring mom and baby, right? We're monitoring their vital signs, the fetal heart rate, and we are monitoring if mom is having any uterine tenderness or any signs of infection. And then the letter M again stands for medications, and we are going to use the proper medications that are adequate for this pregnant person, depending on their gestational age, their symptoms, if they have any comorbidities, any allergies, things like that. So if they are having any potential signs of infection, or we have any reason to believe that they could be at risk for infection, such as maybe we don't have their GBS status, right, because they're preterm in that case, or if they had their rupture of membranes was more than 18 hours ago. Now they're at high risk of infection. Even if they're not having signs of it, we are still going to prevent it, right, by giving them some antibiotics. Again, if the baby has a gestational age less than 34 weeks, then we are going to give them betamethasone to mature their lungs. And then, of course, those tocolytics may be used to delay labor for just as little as we possibly can, in order to allow baby to have a little extra time to mature their lungs, even though we know delivery is going to be imminent regardless, but the more time we can give baby inside, the better. Now, if there is an infection suspected, then we're likely not going to be giving tocolytics to delay labor. In that case, we will be needing to get baby out as soon as possible. So I do hope that that helps you with that ROM mnemonic. And then I see someone saying you purchased the course, you're not able to log in. Do please talk to someone from IT through our chat feature on the website. Hopefully that will be able to help you. That's what's been helping other students if they have ever encountered a tech issue in the past. So go ahead and reach out to them. And then I do see another question here. Is the McRoberts maneuver still acceptable in the management of dystocia? And the answer is yes. The McRobin maneuver is still considered an evidence-based practice. It does help to manage shoulder dystocia during labor and delivery, and it is still practiced to this day. And it actually does involve hyperflexing the thighs of the pregnant person tightly to their abdomen, or straightening their sacrum in order to widen their pelvic outlet. And this can be paired with suprapubic pressure, not fundal pressure, though. Don't get the two confused, right? Suprapubic is different from fundal, right? Fundus is the top of the uterus. Suprapubic is going to be above that pubic bone, and that is to help dislodge that fetal shoulder. So if we are having shoulder dystocia, again, this is an obstetric emergency, we would use the McRoberts technique or maneuver along with some suprapubic pressure. But again, we are never going to apply fundal pressure because this can cause uterine rupture. It is very dangerous. And of course, we will be calling for help with the provider immediately, and then continuing to monitor fetal well-being during that maneuver.
Is the Mark Roberts maneuver where you lift the client's legs all the way over and then press on the suprapubic? Is that what it is?
Yes, I'm going to go ahead and show you some images here. This is what it would look like. So we're lifting mom's legs and we're applying some pressure in the suprapubic area to assist to dislodge that shoulder. Again, only the suprapubic area, not the fundal area, right, which would be the top of the uterus. All right, let me go back here to the presentation, and then let me see what else you guys were asking. Oh, right, I do see the question about amnio infusion, and thank you guys for all your positive comments, by the way. I do see you guys saying great lecture, and I appreciate that so much. About amnio infusion, this is going to be a procedure where sterile fluid like NS or LR is going to be infused into the amniotic sac via an IUPC, which is an intrauterine pressure catheter during labor. And usually this can be done to relieve cord compression. So if mom is, or if the fetal heart rate is showing variable decelerations, and we see that there is cord compression going on, this may be a intervention used to relieve the umbilical cord compression. And it may also be used if we have very thick stained meconium fluid to reduce the risk of aspiration, because this would be diluting that fluid. So it would be like thinning out that fluid a little bit. And if we were to do this intervention, we would need to monitor fetal heart rate closely. Again, this is kind of a standard broad blanket intervention here, is we're going to be monitoring fetal heart rate closely for pretty much anything that we do. But we're also going to be assessing the tone of the uterus to prevent over distension, and we would be keeping an eye on if there's any fluid return. If it's excessive or if it stops, we would be notifying the provider. And then we're going to be watching for signs of infection, because of course we are introducing, even though it is a sterile fluid, we are still potentially introducing something foreign in there. So there could be a higher risk of infection, and we would be watching for signs of uterine rupture as well. All right. Well, I think that covers all of your guys' questions in the chat. You are so welcome. Thank you for all your wonderful questions. These are excellent opportunities for us to discuss everything. So let's go ahead and talk about prolapsed umbilical cord. This is going to be a life-threatening emergency for mom and baby. And this is when the umbilical cord slips down or past the cervix. Sometimes it does slip into the vaginal canal before any presenting part of the fetus. And when that happens, then the cord becomes compressed, right? Because it's kind of like coming out like this. So it becomes compressed between not just the fetus, but also the maternal pelvis. And it can cut off oxygen to the baby entirely, because remember, in the belly, baby's only getting oxygen from the placenta being delivered through the umbilical cord. Baby is not using their lungs in the belly. So again, we're going to need to learn how to recognize this early and know exactly what to do. So first of all, let's talk about what it is. We just kind of mentioned it a little bit, but let's go a little bit deeper into it, right? So this basically means the cord comes down before whatever presenting part of the fetus. Usually it's the head. We hope it's the head, but it's before any other presenting part of the fetus. And usually this will happen after membrane rupture. So again, we talked about earlier, premature rupture of membranes can lead to a higher risk of a prolapsed umbilical cord. And the major risk here is going to be cord compression, which is going to cut off blood and oxygen flow to the baby, which can lead to hypoxia, acidosis, and even death if it's not corrected quickly. Now, some risk factors for a prolapsed umbilical cord are going to be if the baby is not engaged in the pelvis, right? If there is polyhydramnios, too much amniotic fluid, or if we have a malpresentation like breech. And then when the water breaks and the head isn't actually pressing down firmly enough into the pelvis, then the cord can kind of just slip through, and that's when we have to act really fast. And this is actually common with multiple gestation as well. So how do you know that a prolapsed cord is happening, right? So of course, we're going to watch the fetal monitor. As always, like I said, that's going to be our most important intervention. If we do see any sudden bradycardia, that is a huge red flag, especially if mom just had a membrane rupture, right? So mom's water just broke. Now fetus is going bradycardic. Now you have your big red flag alert on. This means the baby is losing oxygen quick, and we need to check if the cord has come down. Now, sometimes the cord may be visible, sometimes it won't be, or it may be palpable. at the vaginal opening. But your first action is not to run and tell the provider. It's actually to act immediately to relieve pressure, right? Because time is tissue. So if you're running to tell the provider, that is precious time that baby is losing oxygen. So you are not running to tell the provider. You're actually going to relieve that pressure. So this is where your priority-based thinking is really going to matter. So again, if you're suspecting or you see a prolapse cord or you palpate it, you're going to grab a sterile glove and you're going to manually lift the presenting part off of the cord if you're able to. You're also going to get that patient into the knee, chest, or Trendelenburg position. This is going to use gravity to move baby away from the pelvis, right? And we have some images here of what that looks like. We're going to apply oxygen, we're going to stop oxytocin, and we're going to give fluids to stabilize mom. Again, this is very similar to our stop and poise mnemonic, except the position is not going to be left lateral, right? The position is going to be either Trendelenburg or knee to chest here. And then once you have mom stabilized as much as you possibly can, you're going to call for help. The provider is going to need to prep for an emergency delivery here, which will usually be a C-section, and this has to happen fast so we can save the fetal life here. Now remember, you're never going to move your hand from the vagina until that baby is out, because that pressure is what is keeping the baby alive here. So I'm going to go ahead and zoom in on some of these images that we have, where if able to insert a gloved hand and lift the presenting part off the cord, that would be ideal. And we have a mnemonic here: lift, shift, and ship, which is lift the presenting part, shift the client's position, and ship to OR. So again, a very, very dangerous situation here. And then next here, I do have some changes in the fetal heart rate. We did kind of talk a little bit about this earlier, where early means head compression, variable means cord compression, and late means placental insufficiency. Again, early is good, but variable and late are bad. So at this position, we would be utilizing our interventions to make sure that mom and baby are okay.
I have a question.
Yeah.
Okay, so for the hard prolapse, when you put your two fingers there, as it says lift, shift, shift, and then ship, right? So do you ask the mother to turn while the finger is there, or is that a different position that you can do otherwise from the lifting the card with the two fingers?
So the first thing that you're going to do is you're going to try to get that presenting part of the fetus lifted. And then you're going to get that patient to the knee to chest position. You're basically going to keep your hand in there the whole time. Does that
While
answer?
they're turning, while they're turning.
Yes. Yes.
Okay.
And yeah,
Understood.
unfortunately, this may be necessary, but only in specific situations where you are able to insert your hand and do that, to kind of hold the weight of the baby off of the presenting part. Again, this would be a really difficult situation. And yes, you would ideally get that pressure off before you get mom to move, because you do want to have as much time as possible where baby is receiving adequate oxygenation. So yeah, you would put your hand in there first, and then while mom is moving, your hand would be in there, kind of lifting. You're lifting the weight of the baby off of the cord.
The card. Okay.
Yeah, exactly. And
I
the
thought
reason
more or less there were two separate things you would do, either or either. So that's what I was wondering. Okay, so now I know. All right.
Yeah, no, that makes perfect sense actually, and I'm so glad that you asked that. But you're right. It would it be either one or the other? No, it would be both, definitely. So the more you do, the better here in the situation. And again, if you don't move that presenting part off of the cord right away, it may even become a worse situation, right? So while you have the ability to, you insert that sterile gloved hand, lift off the presenting part, and then get mom in that position. And like, let's say this was possibly happening like on the road, or an ambulance is coming, there would probably be, either an EMT or a paramedic that would be doing that for you as the mom is being wheeled in. So this would be a rare emergency where, yeah, that would definitely be necessary.
Excuse me, I have a
Thank you.
question.
Yeah, you're welcome.
Yes, I have a question, please.
Mhm.
So
Go
is this the actual procedure to go by? Because I saw a question one time where it says it's contraindicated to put your fingers in there, even with the sterile gloves. So is this the actual procedure? And you need to follow lift the presenting part and then change the position of the mother? Is this always the procedure? Because that question marked it wrong for me when I said that you could put your sterile gloved fingers in the presenting part to lift up the presenting part.
Yeah.
I don't know if you could. Is this just confirm? Because that was strange to me, because I knew this from the textbook that I
Yeah.
used to read, that you're supposed to do that, but that question was marked wrong.
Yeah, that's a great question. I'm so glad that you brought that up. So that is definitely possible. And again, there's never really a never or always, right? Especially when it comes to nursing situations, because every situation is so unique. So we can't 100% say that we always or never would apply something. So sometimes inserting that gloved hand would be contraindicated. Now, the reason why it would be contraindicated, it would be likely if the fetus is compromised or if you don't know exactly if it is a cord prolapse, right? So if you do have cord prolapse, right, you can see it or you can palpate it, and you have evidence that the fetus is compromised. So you're having bradycardia, you're having late or variable decelerations. This is showing you that cord is being compressed. At this point, you would definitely be inserting that hand. Now, the only reason why you wouldn't is, let's say the membranes are intact, right? Membranes are intact, they haven't ruptured, and there's no evidence of a cord prolapse. At this case, maybe you just suspected, but you're not really seeing a compromised fetal heart rate. You're not really 100% seeing it. So you're not, sure if that's what's really going on at that point. That would be contraindicated. Now, another one might possibly be if the patient has an infection. However, the fetus being able to breathe would be a lot more important than the infection, right? So again, it really depends on the individual situation. Now, if mom had a preterm labor, again, but they had no active labor, and we don't want to go ahead and keep, doing any kind of procedure where we're inserting our hand vaginally because of infection risk, that may be a problem, right? But if you know 100% the cord is palpable or the cord is visible and the fetus is in distress, then that would be when you would do it. If for some reason in the question it's indicating it's only suspected, but you haven't seen the cord, you haven't touched it, and the fetus isn't really showing any signs of distress or compromise, you don't insert your hand in there just in case. Of course, also, if mom is having bleeding of any kind, right? If we have we're suspecting a placenta previa or placental abruption, then we would be very cautious to not insert anything in there to further cause damage or hemorrhaging. So there's quite a few different situations where you would have to use your nursing judgment to evaluate if you would be inserting that gloved hand. But for the most part, if your question is clearly telling you that that cord is visible and that you're having non-reassuring fetal heart rate like bradycardia or severe decelerations, then you would insert that sterile gloved hand and elevate the presenting part in order to allow the fetus to have adequate oxygenation. But let's say your question is saying, we have ruptured membranes, but we have a stable fetal heart rate, or no cord is seen or felt. And let's say we're asking for what we would do to prevent a cord prolapse, right? Then it's testing you for just a positioning only case, right? At that case, you would not be inserting your hand. In that case, you would maybe, if you're suspecting that something might start to happen, like let's say, their membranes ruptured prematurely, but the heart rate is stable and we're not seeing or feeling any cord, but we want you to prevent a cord prolapse from happening. In that case, you would just be using positioning, but you wouldn't be actually inserting your hand in there just in case. Does that make sense?
Yes, it does. Thank you so much. In this question, though, it was that the cord was already protruding. So the
Okay.
correct answer was that the patient needed to be put in a Trendelenburg position and not that the finger should be used to lift the presenting parts. So, but I understood what you said. There are different instances, and you have to kind of it's with critical nursing basically. So you kind of have to figure out what the situation is. If the patient was the fetus was bradycardic or stuff like that. So yeah, I understand what you're saying. Thank you
Yeah,
so
that
much.
makes sense. Sorry, go ahead.
I said thank you so much. I appreciate that.
Oh, of course. You're so welcome. And, a lot of the times, again, every facility has different rules, right? But when it comes to the NCLEX, they always want to see something specific. And I say generally on the NCLEX, I've seen positioning come before most things. So even like before you apply oxygen, make sure you're positioning the patient correctly. Before you, even during this problems with labor, when you're doing that poise or the stop mnemonic, you're always positioning mom first. So in that case, it may have been that they wanted you to position mom in the Trendelenburg position first and then do the manual elevation if needed, right? So sometimes it's also in the keyword of the question, right? Sometimes the wording is like, what do you do next? What do you do first? What is the most important? What is the most effective? So yeah, it could
Thank you
be
so
something
much.
like that.
Yeah,
Yeah, of
thanks.
course.
Thanks.
Sorry, I have a
Okay.
question. I'm sorry to interrupt. So, just like she asked, if you were asked the priority intervention to do during the cord prolapse, what would that be? Would it be the repositioning or the putting hand? Yeah, because I've also sent questions like that, but sometimes it is like, what should you do first? And sometimes what is the priority intervention? So if we were asked that, what is the priority intervention? Which of the intervention do you think would be appropriate?
Yeah, it depends on the situation again.
Can
But if
I
we did see this, sorry, go
can I
ahead.
say something? Yeah, I think
Go ahead.
what is important, I think it's like any class we always like, that's what I noticed. Most of the questions, they would give you a cue. Like, for example, like you said, they're gonna say there is a visible cord or something. So then you know if there is a visible cord, like you say, and there is like a decrease in heart rate. So you know you're gonna probably do the elevation with your hand. Sometimes I notice they just say, yeah, so like you notice that the heart rate is like 90 and then they give some cues and then you know you're probably going to do the position. So I think it's mostly like keywords that you have to see on the questions that was going to tell you what is going to be your initial interventions. For me, that's what mostly I noted, like with NCLEX.
Yes, you're absolutely correct. Thank you so much for sharing that. And you're right. It has everything to do with the keywords and how that question is being asked, right? So if the question is saying like, what should you do first? Probably in most situations you would be assessing, right? But then if you already know what's going on, like there is a cord prolapse, it is visible, and let's say that we are seeing that the fetus is in distress, then probably the fastest thing that we could do before we can even get a glove on our hand to insert it is probably to position the client, right? So that would probably be the least invasive, right? Because we always go from least to most. So if it is saying like, what is the priority action? What is the priority intervention that you would take when you know that the fetus is in distress and that cord is presenting, it is visible? What can you do immediately that is going to relieve pressure the fastest, right? I do personally believe that the positioning is going to relieve pressure before you're even able to get that sterile glove on and insert your hand in there to lift the presenting part. You're not going to call the provider first, right? We talked about that. You're not going to do C-section prep. You are going to position the client. Often I see on the NCLEX that positioning comes before almost anything else. So you're going to position that client, knee to chest or Trendelenburg, and then again, you're going to get that sterile glove on, and you're going to go ahead and lift that presenting part to relieve the pressure. So I think it's safe to say do that positioning first and then go ahead and lift that presenting part. And then, of course, afterwards, you can do all the other stuff, administering oxygen, IV fluids, preparing for C-section, whatever. But again, priority here is the top two is going to be positioning and then inserting that gloved hand. And thank you guys all so much for sharing your knowledge. Much, much appreciated. And I do want to jump into this last topic real quick here before we go into our case studies. So we're going to talk a little bit about amniotic fluid embolism. This is kind of a rare occurrence, but it is a very, very rapidly fatal complication in OB. It can happen completely without warning. It can happen during labor, during delivery. It can even happen shortly after birth. So this is a very dangerous complication. It hits the patient very suddenly. It can lead to cardiac and respiratory arrest, and it can lead to massive clotting issues within just minutes of it happening. So basically, an amniotic fluid embolism, also known as an AFE, is going to be a very, very rare, again, but very fatal obstetric emergency. It is one of the deadliest complications that can happen to a mother during labor or right after. And what happens basically is the amniotic fluid or any like fetal material can actually enter the maternal bloodstream. And then the body, of course, will react to it like it's some kind of a foreign invader. So then the body will cause a collapse of your cardiopulmonary system very suddenly, and of course, coagulations. So this can happen again at any point during labor, delivery, or shortly after. It can come on very suddenly. Your patient may be smiling, maybe fine 1 second, and then the next minute they will be completely unresponsive. And some risk factors for this are going to be advanced maternal age, so moms over 35, placenta previa or abruption, multiparity, so having had multiple babies, cesarean or instrumental delivery, and uterine rupture. Now, the hallmark here is going to be a very dramatic presentation for AFE. The mom may say something to you, or they may not even, they may just collapse. But they may tell you, I can't breathe. They may grasp their chest. They may become cyanotic, right? They may have blue lips, blue tips of their fingers. They may start to develop central cyanosis and signs of shock. They may become hypotensive, restless, confused. Again, the presentation will be dramatic. It will be sudden. And as the embolism triggers the systemic inflammation and coagulation, you're going to see signs of DIC, including possible oozing from IV sites or even postpartum hemorrhage or all of it at once. And your key here is going to be your speed, okay? You're going to have to act very quickly. There's no time to run labs. We're going to recognize and treat this condition simultaneously. So you're going to think rapid response and resuscitation right away. So if you are suspecting AFE, I want you to immediately call for help, right? You're going to hit that code button. This is not a wait and see. Wait, oh, I don't know. I don't want to call them just in case. No waiting. Hit that code button, start high flow oxygen immediately, and prepare your client for intubation. And if needed, you may have to begin CPR and start fluid bolus and vasopressor support. You're going to monitor your client for DIC symptoms, and you're going to have blood products ready. Of course, as soon as you hit that code button, you're going to see everybody running in, and everyone is going to take charge. Each person is going to have a role. You're not going to be doing this all by yourself again. But on the NCLEX, you're answering the question by yourself. So remember, you're going to activate that emergency response system. You're going to initiate CPR. If the mom does go into cardiac arrest, you're going to administer oxygen via non-rebreather or a bag valve mask. And you're going to prepare the client for intubation if necessary. You want that large bore IV access so you can give rapid fluid resuscitation and possibly blood products if DIC develops. And you're going to want to stabilize that blood pressure with vasopressors. Now, if mom is in labor, we may have to deliver the baby extremely quickly, usually via stat C-section, in order to increase the chances of mom and baby surviving. Let me see. All right, so we have a mnemonic here, Save Mom, and it does just kind of let you know some of the interventions that you're going to need: support the airway, administer O2, monitor the vitals, emergency code, massive transfusion, OB console, and mechanical ventilation. Remember, you're not going to be working alone in a clinical setting. Your job is just to recognize this is happening and start that response very quickly, and of course, support the team in whatever way you can. I do have some quick Q&As here for you. The first sign of AFE is going to be sudden shortness of breath, chest pain, or cyanosis. So again, mom can be sitting there happy, smiling, or even in the midst of labor, and all of a sudden they may grasp their chest, they may become anxious and restless, they may become cyanotic, they may say, I can't breathe, and suddenly collapse. Again, your priority intervention here is going to be to call a code and to begin oxygenation and resuscitation protocol. And if there is a any DIC, again, you're going to want to have blood products ready. And of course, that is the clotting complication that's common here with AFE is DIC. What should the nurse anticipate for a client in labor with AFE? That would be emergency C-section and ICU transfer. We got to get baby out of there as soon as possible. And the mortality rate is going to be very, very high with this condition. Prompt action is absolutely critical. All right, let's go ahead and jump into our case study here. So we have a little bow tie case study. I didn't put it in the presentation. It's just kind of easier to read it like this. So, whoa, big zoom here. I'm going to go ahead and read it to you guys. We have a nurse that's caring for a neonate in the postnatal unit. And that neonate was delivered via spontaneous vaginal delivery at 40 weeks gestation. Labor was prolonged, with second stage lasting over 2 hours. The attending provider noted shoulder dystocia during delivery. The neonate cried immediately after birth, but has since shown minimal spontaneous movement in the right upper limb. No bruising is noted. Feeding attempts have been difficult with weak suck. The neonate appears irritable during handling and is particularly fussy when the right arm is moved. Parents report concern over persistent asymmetry when holding the baby. Our medical history includes full-term gestation at 40+1, maternal age 35, GDM diet controlled, no antenatal infections documented, no intrauterine growth restriction noted. Birth weight was 8.4 pounds. APGAR scores were 8 at 1 minute and 9 at 5 minutes, which is excellent, and no congenital anomalies identified antenatally. We have a temperature of 98.1, a heart rate of 142, blood pressure of 68/42, oxygen sats of 96% on room air, and respiratory rate of 52 breaths per minute. This neonate is alert and responsive to auditory and tactical stimuli. The right upper extremity is held in adduction and internal rotation with absent moral reflex on the right side. There is decreased spontaneous movement in the right arm compared to the left. Passive range of motion at the shoulder and elbow elicits a mild grimace. There's no swelling, erythema, or crepitus over the clavicle or humerus. Grasp reflex is present bilaterally. Neck movements are symmetric and the spine is without abnormalities. Tone is appropriate in lower extremities and pupils are equal and reactive to light. We have a white blood cell count of 9,300, which is within range. We also have a CRP of 0.6, which is below the normal range, or it's within the normal range, I'm sorry, and then the serum glucose of 42, which is kind of low, but it's still within range. Our blood cultures are pending. We don't have any intracranial hemorrhage, and the clavicle looks intact without fracture. Now, we're going to go ahead and choose the condition most likely experienced, the actions to take, and the parameters to monitor. Can someone tell me what they think these answers are and why? I'm seeing C here. Neonatal brachial plexus palsy. I'm seeing B.
The correct answer is A.
You said the condition is A, macrosomia?
I missed how much did it weigh? 8 pounds or something. It could. I want to say it's
That was, baby was 8.4 pounds.
Okay. So
The answer is A. Marcosomia. Can you go back to the statement?
Yeah.
I wasn't reading. I was just.
Sorry about that. The zooming was a little dramatic there. All right, there we go. We've got our
Not that part.
So the correct answer would be microsoma because the baby was 8 pounds, 4 ounces.
8.4. Typically, macrosomia is after 9 pounds. So,
can you go back to the scenario?
I think it's B.
Yeah, absolutely.
It's
so,
C.
I think it's B.
It's B because it's the range of motion is limit.
Yeah, but
I
and
just
then-
guessed the answer. That's why I want you sure to go back to that. Because I just guessed the answer. I'm not sure of it.
So you
I
guys
have a B. I have a B,
right.
but I'm not sure.
Yeah, those of you who said C are right. It is neonatal brachial plexus palsy. I'm sorry, palsy. And then the two actions that we're going to take here are to position the neonate to avoid pressure on the affected limb, and then to immobilize the affected upper limb with a rigid splint. And then the parameters are going to be capillary blood glucose and neurovascular status of the right upper extremity. This has everything to do with that extremity that was not moving correctly, right? So neonatal brachial plexus palsy here does result from traction injury during shoulder dystocia. The right arm held in adduction, internal rotation with that absent moral reflex, where they kind of move their arms out when they feel like they're being dropped. And then it says preserved grasp reflex indicate Erb's palsy, which is an involvement of the C5 and C6. Now, this fits the clinical picture without signs of fracture, no tone, no bruising, and intact reflexes elsewhere support a neurologic rather than skeletal cause. The injury often occurs in large for gestational age infants with prolonged second stage and traction forces. So those were kind of the key words in there. Now, again, we are going to position to avoid pressure here. We don't want any additional injury. And of course, we're going to go ahead and handle them very gently and immobilize them with that soft splint to kind of allow the injured limb to rest, to prevent any contractions, and to promote recovery. When it comes to our correct parameters here, our capillary glucose needs to be monitored, right? Because the neonatal brachial plexus palsy can impair feeding and suck reflex, and their blood glucose is already at 42, so it's getting low, it's getting there. So we definitely need to monitor their glucose. And again, their neurovascular status also needs to be monitored because we need to make sure that they are perfusing correctly, that they have motor function, and that there's no other complications coming through like edema or compartment syndrome. So great job. You guys had a great discussion there. All right. Let's go ahead and do another little case study here. So we have a nurse that's caring for a 26-year-old female client in the OB unit. The client presents with complaints of a sudden gush of clear fluid from the vagina 3 hours ago. So again, that's very recent. The client is reporting mild lower abdominal discomfort but denies vaginal bleeding. She states feeling damp and notices a constant trickling of fluid. So we know that she might have had a premature rupture of membranes. The client verbalizes concerns about the baby's well-being. She denies fever or chills. Fetal movements are present but perceived as reduced, and she has no history of recent trauma. So no signs of infection yet, right? We have 35 weeks gestation, gravida 2, para 1, Group B strep positive at 33 weeks gestation. So not only is she preterm, she's also GBS positive. So we're anticipating antibiotics here, right? No history of GDM or hypertension, previous delivery at 38 weeks without complications, and documented penicillin allergy. Now the temperature is 100, so this mom may be developing some infection signs here. Heart rate 104, definitely. She's getting tachycardic. Her blood pressure is 122/78. That looks good. Respiratory rate is 18 per minute, and oxygen sats are 98. Upon physical examination, this client appears anxious. There's clear fluid pooling in the vaginal vault on speculum examination. The cervix is closed and no active bleeding is noted, so that's good. The abdomen is soft with mild lower uterine tenderness on palpation. Again, that is a sign of infection, right? That uterine tenderness. No fundal tenderness is noted. Fetal heart tones are 145 per minute on Doppler. This is great. Baby's within range, 110 to 160. And there is no visible umbilical cord prolapse. All right, so we're going to go ahead and highlight the findings that require immediate follow-up. The client presents with complaints of a sudden gush of clear fluid from the vagina 3 hours ago. She reports mild lower abdominal discomfort but denies vaginal bleeding. She states feeling damp and notices a constant trickling of fluid. The client verbalizes concerns about the baby's well-being. She denies fever, chills, and fetal movements are present but perceived as reduced. She has no history of trauma. And we have here her medical history and her vital signs. So what do you guys think we are going to be highlighting here? So remember, our question is highlight the findings that require immediate follow-up.
The temperature and the heart rate.
Sudden gush of fluid from the vagina 3 hours.
from the vagina.
Mild abdominal discomfort.
Yes. We have that uterine tenderness, right? Where is it here? We have uterine tenderness on palpation. Let's see. I'm just highlighting everything you guys are telling me, and then we'll go over the answers.
You can zoom. The letters are too small to view.
Too small?
35 weeks of gestation.
Mild lower abdominal discomfort.
Okay.
What about the fetal
Group
movements
B.
are present but perceived as reduced?
Definitely.
Strep B positive. That.
All right, let's take a look.
Heart rate. Okay. The heart rate.
Yes, her heart rate, right? She's 104. So here's our answers. We have sudden gush of clear fluid from the vagina 3 hours ago. You guys are correct, right? That is definitely something we need to follow up on right away because this means she's had a premature rupture of membranes. Fetal movements are present but perceived as reduced. We always need to pay attention to when we have decreased fetal movement. Again, group B strep positive at 33 weeks gestation, right? This means she's going to need antibiotics and that she's only 33 weeks gestation, so she is definitely very term. Now, the heart wasn't one of the options here, but we do have clear fluid pooling in the vaginal vault as one of the options, again, because there is clear fluid leaking, right? So this means she's preterm and she's had a rupture of membranes. This means that she is at a very high risk for infection, right? Fetal movements are reduced. This means the fetus could be compromised or distressed, so we need to monitor closely. Again, GBS means we're going to need some antibiotics here. And then that clear fluid pooling is going to mean we have that premature rupture of membranes, just like I said. Now, these other findings here did not need follow-up. Again, these are normal. Denies vaginal bleeding is normal. Previous vaginal delivery at 38 weeks without complications, normal. Cervix is closed, normal. And respiratory rate, 18 breaths per minute, normal. So great job, you guys. You definitely recognized some dangerous complications there. Now let's go ahead and look at these responses here. The client is most likely experiencing as evidenced by. So who wants to tell me response 1? What is the client most likely experiencing?
Preterm, yeah.
Absolutely. Definitely A, right? So we have a premature rupture of membranes here, and then as evidenced by
C.
Sudden gush.
C.
You guys are absolutely correct here. Again, they are experiencing PPROM, right? Because this is happening before 37 weeks of gestation, and they are having a sudden gush of fluid that is pooling in the vagina. So this means that they definitely had an amniotic sac rupture. They're GBS positive, right? So this means that they're at very high risk of infection right now, especially because this mom is already tachycardic. She's feeling reduced fetal movement. Her heart rate is high, and she has a fever right now. So it may not be full on considered a concerning fever. It's only at 100 right now. Usually we're concerned after like 100.4, but still it is significant. It is clinically significant here. Now, there's no reason to think she's having a placental abruption. Preterm labor, we don't know yet. We just know that she's had a premature rupture of membranes, right? But we don't know if she is having signs of labor because her cervix is closed, and there's no mention of contractions. Now, we do have a positive GBS colonization here, but this isn't the primary evidence for that the preterm premature rupture of membranes. And then that elevated maternal temperature here could be indicating that they are developing an infection, but it doesn't necessarily mean that they have one. Again, it's just starting. So we're going to go ahead and take a look and trend that that value there. All right, let's take a look at our diagnostic results here. Our white blood cell count is elevated at 17,500. Our C-reactive protein is elevated at 2.6. Our amniotic fluid analysis is positive for gram-positive cocci, and our nitrazine test is positive, which means we definitely have amniotic fluid leakage. And our fetal fibronectin is positive, which means delivery is imminent within the next 7 to 14 days. So let's go ahead and choose if these actions are indicated or not indicated. So does anyone want to tell me what is indicated or not indicated in this case?
Administrate.
Antibiotics is indicated.
Indicated.
Are we delaying delivery until full term?
Not indicated.
No,
No.
not indicated.
Are we administering corticosteroids?
Yes.
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 Yeah.
Indicated.
Are we obtaining blood cultures?
Yes.
Yes.
Yes. Indicated.
Are we
No.
performing a
No.
vaginal examination?
No, not
No.
indicated.
And are we providing tocolytics?
Yes.
Yes.
Hmm?
No. No.
Why?
Oh, because we delay. Yeah, we delay.
No.
You cannot
No,
delay
because
this
of
Yeah.
the fibronectin. Yeah.
Yeah.
No.
All right, so let's go ahead and take a look. So we definitely got that one correct. We're not delaying until full term. We are administering corticosteroids and getting blood cultures, and we are not performing a vaginal examination. Great job, you guys. And for some reason, this is not showing the last one here, which was provide tocolytics, but we are not providing tocolytics at this time. Again, we're not having any contractions, right? There's no sign that she's actually going into preterm labor, so that's not necessary. But you guys did a great job here in using your nursing judgment. We are definitely administering antibiotics. We're giving her betamethasone because we know delivery is imminent, baby's coming soon. So we got to mature those fetal lungs, and we're definitely getting blood cultures because her CRP and her white blood cell count are elevated. She's GBS positive. She has had a premature rupture of membranes, so she's she's tachycardic, she's feverish, she's definitely showing signs of infection. So we're definitely doing blood cultures here. But are we doing blood cultures first, or are we giving antibiotics first?
Doing blood culture.
We're doing culture first
Yes, culture first.
before antibiotic.
I like me.
Absolutely. Yes, I love to hear blood cultures first, always, then antibiotics. So we're going to give some broad spectrums. And then if necessary, if there's some kind of a unique organism in there, then we might change antibiotic course. But again, blood cultures first, always. We are not delaying delivery until full term, right? Because there are signs of infection, and we're not performing any vaginal examinations because we don't want to further increase the risk of infection and introduce more organisms into the vaginal canal. Now, yeah,
because of the positive fibronectomy, fibronectin test, is that not enough reason to give the tocolytics?
you're saying because of positive fibronectin, are we giving tocolytics?
Is that wouldn't that be enough reason to give the tocolytics?
Absolutely, we could potentially give tocolytics, but it depends again on the situation here. If she is having contractions, if she's having any signs that the cervix is opening, then we might give tocolytics. Again, that would be depending on the patient or what the physician would choose. Now, typically a positive fibronectin test between 22 and 34 weeks would mean that, again, we are having labor being imminent within the next 7 to 14 days. That should not be present. So just because it's positive, that doesn't mean we automatically start tocolytics because she's not showing signs of preterm labor, right? So if she was having, it did say her cervix was closed. So if she was having an open cervix, if she was like maybe dilated 3 centimeters, effaced 80%, or if she was having contractions, then yes, we would definitely start some tocolytic therapy. However, she's not, right? She's not having any signs of preterm labor. Her cervix isn't changing. It's staying closed. It didn't have any mention of contraction. So at this point, we are just going to continue to monitor. We're going to educate her to report any signs of imminent labor for us, and we're definitely going to be administering those corticosteroids to mature the fetal lungs. And she is likely going to be admitted at this point. We're probably not letting her go home, right? Because she's got signs of infection. She needs IV antibiotics. Her membranes are ruptured. She's preterm. So we're definitely keeping her in the hospital. But again, we are not giving tocolytics until we have signs that labor is actually happening. So again, cervical changes or contractions. And that was a great question. Thank you for asking that. So for each finding, click to specify if the finding is consistent with chorioamnionitis or placental abruption. What do you guys think? Maternal fever, is this chorioamnionitis or placental?
Oreo.
Choreo. Fetal tachycardia.
Choreo.
Placenta abruption.
Placenta abruption.
So we're saying both on this one. Cloudy, foul-smelling amniotic fluid.
Choreo.
Sudden onset of abdominal pain.
Placenta.
So you said that one already.
Uterine tenderness.
Placenta.
And choreo too, both.
All right. Great job, you guys. So definitely here, maternal fever is going to be chorioamnionitis, fetal tachycardia, both, right? Cloudy, foul-smelling amniotic fluid, choreo, sudden onset of abdominal pain, placental abruption, and uterine tenderness, both choreo and placental abruption. Great job, you guys.
I was saying that, but you didn't hear me.
With your nursing.
Professor, can you scroll down back a little bit, please?
The placenta the placenta previa is painless. So that one was wrong. I was telling Professor, but he didn't hear me.
Oh, I'm so sorry. I'm so sorry I didn't hear you. Yeah, so this was placental abruption, not previous. So yeah, you make sure to know the difference between the two. Sometimes we may see one and think we're talking about the same one, but yeah. So placental abruption is definitely sudden, whereas chorioamnionitis and placental abruption will have uterine tenderness. So I hope that helps. And are you guys okay with me moving down?
Yes.
Okay. Thank you for telling me. So next question here. We're getting close to our last question. So Provider's orders we got at 7:30, right? We're going to administer gentamicin IV at a dose of 5 milligrams per kilogram once daily. We're going to administer betamethasone 12 milligrams IM every 24 hours for 2 doses. We're going to administer clindamycin 900 milligrams IV every 8 hours. We're going to administer cefazolin 2 grams IV as an initial dose and then 1 gram every 8 hours until delivery. We're going to monitor maternal and fetal status every 2 hours and perform sterile speculum examination. Now, the nurse is reviewing the provider's orders. The nurse should clarify the prescription of one during the risk, I'm sorry, due to the risk of 2. So what do you guys think?
Gentamicin.
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 And why is that?
Because of the pregnancy.
She's
Is it because of
allergic
fetal
to. She's
distress?
allergic to. She's allergic to
Fetal
penicillin.
distress.
Yes.
So it's
Allergic
actually cefazolin, but you guys were right. You were on the right track because of that allergic reaction, right? She's allergic
Yeah,
to
she's
penicillin.
allergic to penicillin.
Yeah, so you guys were on the right track. Absolutely. That allergic reaction, as nurses, we're the last line before medications get to our clients and harm them, right? So we're going to always check our allergies. Cefazolin is a cephalosporin antibiotic, which is related to penicillin. So again, we're not going to give them cefazolin unless in some cases we may give a medication that has cross reactivity if that's the only medication we can give. And if we have reported reactions that are basically just like, oh, I just get a rash or I just get hives, it's not as serious. Again, this would be like a life or death situation. And in that case, the physician would likely be ordering antihistamines and any other medications that they can to slow down that allergic reaction in addition to the medication. But that's not the case here. She definitely has other options besides cefazolin. So again, great job. That is definitely the one that we would choose here. Again, gentamicin is an aminoglycoside. There's no known cross-reactivity. Betamethasone is a corticosteroid, so this one has nothing to do, right? She has no allergies to that. The sterile speculum examination is okay, right? There's not any significant risk here with that one. And then again, these fetal lung immaturity here, betamethasone. Again, that's what we're using the betamethasone for. Cefazolin has nothing to do with the fetal lung immaturity. Fetal distress wasn't really the right answer here. Neonatal sepsis, again, wasn't the right answer here. Was that our question number 6? That was number 5. We have one more to go. All right, we have the client reporting a decrease in lower abdominal discomfort and denying chills. The client denies further leakage of fluid. She continues to express concerns about the well-being of the fetus. IV fluids and antibiotics have been administered. Fetal heart rate monitoring is ongoing. The client received the first dose of betamethasone and remains hemodynamically stable. This is amazing. No new complaints have been reported. Now, temp has gone down to 99.7. Heart rate has gone down to 96. Blood pressure is 118/76. Respiratory rate is 18 breaths and O2 sats are 98. The client is alert and cooperative. Abdomen is soft, no new tenderness. Speculum examination shows minimal residual clear fluid. Fetal heart tones are 140 per minute with moderate variability, and the uterus remains non-tender and no contractions have been palpated. So there's no signs of imminent labor yet. Now, the client asked the nurse about causes of preterm premature rupture of membranes. Which of the following potential causes should the nurse include? What do you guys think? And it looks like this might be a select all.
A.
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 Okay.
Yes.
F.
Oh, it's multiple.
E.
Yeah.
Smoking during pregnancy.
Yes.
Smoking.
And F.
And bacterial vaginosis. So again, we have intraamniotic infection, cervical insufficiency, smoking during pregnancy, and bacterial vaginosis here. These are going to be the reasons or causes why this person may have premature rupture of membranes. That is preterm, right? This means it ruptures before 37 weeks. If we have cervical insufficiency, smoking, bacterial vaginosis, and infection, these can weaken the membranes, leading to rupture, right? Cervical insufficiency means the cervix is dilating prematurely, but she doesn't have this, right? Her cervix is still closed. Now, smoking is just related with all adverse outcomes in pregnancy, and BV can ascend up into the amniotic sac, and it can cause inflammation. It can weaken the membranes. And of course, we have some other causes here that weren't listed, like previous preterm births, multiple gestations, polyhydramnios, and that's it here. So the other ones, these are the rationales for the correct answers here that we just talked about, and some take-home points for you guys. I will leave this up here as we wrap up. It is within our 2-hour mark here, and I just wanted to thank you guys for working through all these topics with me. This was a super comprehensive study here, and lots of different topics we talked about problems with labor, and you guys did so amazing answering the questions. I just want to thank you guys for being here today. I want to share with you our website here in case you do want to check out our question bank, and you can check out our free trial. And then I also have a link here for feedback. If you guys do want to give some feedback about the webinar today, let me know if you liked it, if you didn't, what do you want to see again? Let me see if I'm able to copy and paste that here. And it looks like we do have a webinar taking place actually. I believe right now at 6 o'clock PST or 9 o'clock. Let me see.
It's supposed to be at 9 o'clock. That's going to be a different representative.
Yes, if there is one today, it'll be a different tutor. Okay. And we do have webinars happening pretty much every day of the week. So go ahead and check it out on our website every day. I am going to be doing another one Thursday and Friday this upcoming week on hematologic disorders. And then also on postpartum period complications. So we are going to talk about lots of new topics Thursday and Friday. So I hope to see you guys there. And if not, then I hope you guys enjoy the rest of your weekend and the rest of your week. And thank you so much for coming today. Again, it's always a pleasure seeing you guys. And I'm so honored to be here with you. And if there's any final questions you want to ask me before I go, let me know. And I do see here, I was trying to look on the schedule. I didn't see what we had at 9 o'clock, but we do have Ferdinand sharing here that we have a webinar on mental health happening right now at 9 o'clock Eastern time and at 6 o'clock Pacific time. So if you guys want to go ahead and jump on that one right now, feel free to. And I do see, Professor, are the questions available, please? So our questions are available on our question bank. We do have lots of questions and case studies that you guys can check out. But I do encourage you to download our presentation slides. They are available on the website. Every presentation that we have, we upload our recorded webinars and we upload our presentation so that you guys can download them and use them as a study guide. So thank you guys so much for being here today. I hope you all have a wonderful rest of your weekend. Happy Father's Day to everyone out there. And sending much love to all of you and good luck on your NCLEX. If any of you are taking it this week before I see you, best of luck to you. You definitely have got this. I believe in you. So you should believe in you too. You guys have a wonderful week. And again, thank you so much for being here today. Take care, you guys.
Thank you so much. Have a good evening. It was wonderful lecture. I really, really learned a lot today.
Oh,
But
good.
that was,
I'm
yeah.
happy to hear that. Thank you so much. I
Thank you.
appreciate you. You have a wonderful evening too.
Okay, you too. Thank you.
Bye.
Bye-bye. Bye-bye.
Bye-bye, you guys.
Bye.
Bye.
Bye, Professor. Thank you.
Bye. You're so welcome. It's my pleasure.